Now, when are we going to forego this delivery at 38 weeks? It's when, one, there's profuse bleeding vaginally, leading to potential or actual hemodynamic instability, meaning vitals crash and so on. And number three, preterm labor. There it becomes a Caesar start. No wonder we say that you have to go for expectant management. It's not conservative, it's expectant, meaning that you look as if you're just greeting the patient every day. Oh, how are you today? Any problem? No, I've got no problem. Are you bleeding? No. You go. Patient will even be saying, I would have even been home then. Because it's like here, they're just giving me folic. This folic I can take at home. I even just stay behind the hospital. But for those of you who've seen how unpredictable placenta previa is, you are from talking to the patient, the next 2 minutes, patient starts pouring like a tap. So that unpredictability happens because of what I was saying. The growing of the lower uterine segment is unpredictable. So the shearing can happen anytime. And if it's massive shearing, the patient will start pouring. That explains why we don't even have room to start asking the one who is on. It's not Dr. Where is the file for this patient? Imagine you work in pediatrics. What patient is this? What are the doctors managing? You should have a delivery plan written in red pen, capital letters, and I've seen how people like making shortcut delivery plans, but I will not discuss it in this lecture. A delivery plan is a very big undertaking. There must be the name, the age, the phone number, the word, there must be the diagnosis, there must be the timing and mode of delivery. Then you should outline almost what I've written in the notes as it is up to the end. So that becomes your delivery plan. You should countersign, you who has formulated it, and probably your consultant or your SRMO or GMO, whoever is taking lead, because you have now written a delivery plan. It should be stuck on the front page of the file. It's not only in placenta previa, but in other conditions such as you can draw the curtain. In other conditions such as cardiac disease, diabetes mellitus, and so on. Okay, let me conclude with the lesser taxing part, which is placental abruption. What does management of placental abruption depend on? So in abruption, management depends on, number one, gestational age, number two, hemodynamic status as well, but three, there's also fetal viability. So whenever you've got a patient with placental abruption, those are some of the aspects you consider in your management. Now, there are only two indications why we offer cesarean section in placental abruption. Two. Number one, it is for a viable fetus at or near term. If the baby is alive and the gestational age is salvageable, meaning this is a baby that the woman can go with, not at 22 weeks. Let's say 36, abruption has happened at 37 weeks, 35, the baby is alive and you are sure it's an abruption. You get the point, eh? You need to quickly get the baby out. I still remember my teacher. Can I mention her name again?
Yes.
Miss Gracilia Mukumu, retired gynecologist. She told me that you have to deliver by the quickest, next, safest, and finally, most feasible option. Meaning that consider those aspects. Now, the rest, if it's not satisfying viability, being assured, and at or near term, then have second thoughts at cesarean section. But what other reason? Going by what my teacher told me, this. It means that a hemodynamically unstable patient, meaning there is profuse PV bleeding or patient is in shock, the quickest and safest probably will be cesarean section. So let me conclude by saying for abruption, cesarean section will be 3 things. Okay, let me say 2. Fetal viability assured at or near term, let's put it as 1. And the other one is hemodynamic instability. Because you know that a cesarean section will be the quickest way of getting that placenta out as opposed to induction or augmentation. Does it make sense? Okay, now let us assume the way we assumed here that patient is number 1, hemodynamically stable. Number 2, fetus not viable. This is usually the scenario that we have. Patient is hemodynamically stable, but fetus not viable. What are we going to do? Number 1 is the same. Admit. Now you can't admit to the ward. Abruption is an emergency. I've never seen an abruption in the ward. It's even now from banana blankets. They're even eating in gym. Remember, we said that if it's indeed an abruption, then there should be an element of seriousness and an emergency environment. So you should put 2 IV access, probably now large bulk cannulas like 14 to 16 G. Number 2, obviously you collect bloods. Remember, we are now at investigations. Which investigations do we do for abruption? Number 1, full blood count, almost similar to the other one. Number 2, we group and cross match. Now, we don't group and cross match for raw blood only, but we group and cross match for number 1, raw blood, number 2, fresh frozen plasma. Sometimes you might be forced to even go to platelets, you might even be forced to go up to cryoprecipitates. There are even some other blood products that I have not seen here, like what is called the recombinant tissue, recombinant factor 7 and also prothrombin complexes. Yes, but in our setting, like here in Zambia, I think we normally use raw blood, platelets, FFPs, cryoprecipitates. And that now is exemplified by what is called Pack 1, Pack 2, Pack 3. I think we talked about this some time back. Now, why are we including FFPs? It is because of the risk of DIC, which is more in placental abruption. That is why think of coagulopathy all the time. No wonder you are including FFPs, because they are rich in clotting factors. Number 2, in addition to the FBC and the grouping and cross-match, you should also go further to do bedside clotting time and clotting profile. So bedside clotting time is extremely important, so that if blood cannot clot in a red top, then it means that even in blood, the process has started. Clear? And a full clotting profile, if you can manage using a blue top, meaning you do a PTT, which is activated partial thromboplastin time, prothrombin time, and so on and so forth. So, why am I not including obstetric ultrasound? Obstetric ultrasound maybe for the purposes of fetal viability, but not for diagnosis. Because I've seen people sending patients for ultrasound to diagnose abruption. Abruption placenta is a clinical diagnosis. Again, that's what I was told by my teacher. Oh, it's keep mentioning. So, it's a clinical diagnosis. Meaning you've taken a history, you've examined. Because a scan can be misleading. I don't know how many of you have seen a scan being done. A placenta looks like this. It looks like it has got a tip and a tip. That's how a placenta looks like on ultrasound. It is the... Anyway, I'm told that there will be a training on the ultrasound, basic ultrasound. So let me not preempt it. But what I'm trying to say is that in most cases, there seems to be a detachment line between a placenta and the uterine wall. That's normal. So if your sonographer is not so much experienced, they will see this detachment as an abruption. Yet it's normal. So I feel really that abruption diagnosis is purely clinical, and I agree with my teacher several. Ultrasound maybe just to know that the fetus is viable or not. If at all you can't pick it using clinical methods. Now, what else did we say in terms of treatments? We've talked about fluids. So normal saline or Ringer's lactate preferably should be started. Right? What else should we be doing? We need to give the 4 to 6 units of FFPs before she delivers. Because ultimately you are trying to achieve a vaginal delivery. In that scenario I've given you, patient is relatively stable and the baby is gone. So in most cases, you find that the patient would already be in preterm labor or would be in labor. But if they are not in labor and you have assessed the Bishop's score, then you might need to give some prostaglandin like misoprostol so that the cervix ripens and it dilates. Now, in the process of waiting for vaginal delivery, you are supposed to give fresh frozen plasma so that you offset the coagulopathy. Mind you, these clotting factors are being consumed. You are trying to replace them. If you think the patient is worsening in terms of anemia, you can even give the red blood cells. You can give red cell concentrates or whole blood. Maybe 2 units. But don't give all the whole blood. Keep some on standby for delivery. Because remember what we discussed yesterday? We said that the PPH is likely to be the point at which they will decompensate. Now imagine you transfuse that all that blood has come out. It has gone behind the placenta. What have you achieved? So all you need now is to have some blood on standby. Clear? Next, adequate analgesia. This is a patient who is in pain. Why should you continue allowing them to be in pain? So give pethidine, give fentanyl, give everything that you can give, including diclofenac, because this is a patient that, the baby is gone. So you can give morphine, you can give any options that you have. Then please aim to, at the quickest possible opportunity, do an ARM and augment labor. Again, we have observed from experience that placental abruption responds very well to oxytocin infusion. It's very rare to have a failed induction in an abruption. We don't understand why, and we probably haven't researched more, but we know that the abruptions respond well. So don't rush to say failed induction, failed augmentation. If you just give oxytocin with the necessary milli-units that are supposed to be delivered per minute, or the correct drop factor, definitely the patient will deliver. Then monitoring. What do we monitor? Remember vitals, SpO2, everything else that you need to monitor, including vaginal bleeding and everything else. But don't forget in all this equation, urine output. So input-output monitoring is extremely crucial in placental abruption. Now, before I go to second stage, one of the things that we need to find is that if the cause of the abruption is preeclampsia, I've just mentioned that fluids are important. But preeclampsia, we only go for the placenta. It will also go for the lungs also. It will also go for the brain. So there's risk for cerebral edema and the pulmonary edema. If you give too much fluid, again, you will cause another problem there. So how do you balance to know that this is not too little, this is not too much? We are just from a discussion where we are talking about the role of central lines. What is known as central venous pressure monitoring. That will remain the best marker of knowing whether the fluid is too much or too little. So it's a quest, it's a clarion call on our ICU and HGU to be able to offer such type of monitoring, which is more standard. Rather than you waiting for a patient to start coughing, being frothy sputum. Patient goes in respiratory distress, desaturates. That's too late because the problem has already occurred. Clear? Finally, we need to have MO present at the second stage for what I just mentioned, and I want to repeat that. Meaning you should have TXA, you should have misoprostol, you should have everything that you need. because the time frame might not be there once you have a huge intraplacental clot which follows the placenta upon removal. Because now what will happen is that patient will have atony, at the same time will have coagulopathy. So you have two T's that will be fighting you in terms of the PPH. So TXA could have been given before delivery, but you need to repeat it again after delivery. So we institute what is known as aggressive PPH prophylaxis, meaning misoprostol 800 micrograms per rectal, whether or not there is PPH, but that should be given. Oxytocin infusion, now increase it to 20 international units in 500 ml of fluid. Then you also add repeat TXA, and also you do uterine massage. Obviously, active management of third stage could have already been done, and obviously you keep the patient in the high dependence unit. This obviously you cannot manage a rupture in an ordinary labor ward, but in a high dependence unit. At least, not necessarily ICU, but high dependence unit. And keep that patient for another 24 hours so that you can see the input output. If you won't need the blood, the EPL will be minimal. No need to give the blood. If you think the patient has bled a bit, that's when you can give the whole blood, because you are giving it at a point you have achieved the homeostasis. Clear? That is where we end with our discussion of placenta previa and placental abruption. Let me just mention here that why did I talk about gestational age for placenta previa? It's because if a patient comes at 38 weeks and is placenta previa, why should you keep them? You deliver them immediately, also. But if it's before 38 weeks, it means you need to buy time. At least allow the baby, give the baby a chance at life by allowing the baby to have the lungs mature, so that at that point you deliver. So, colleagues, this is where I end. I don't think I've not mentioned any other aspects of this. Serum creatinine is not really important in placental abruption initially, unless you just want to use it as a baseline. Otherwise, if you manage the fluids properly, you might not even end up with acute kidney injury. And again, if you predict the coagulopathy early and give FFPs and TXA, and hopefully in future we will start doing serum fibrinogen, which is a very important predictor of DIC or other forms of coagulopathy, then probably we can act a bit faster, because DIC has got two types: slow evolving and rapidly evolving. Rapidly evolving is nasty, and on that one, if you don't have FFP, you don't have cryoprecipitates, you don't have fresh whole blood, it is a nightmare. And I shared with you what was an obstetrician nightmare and which one was a surgeon's nightmare, according to me. So, okay, end.